We'll do a quick mic check. Josh, can you just unmute, make sure we can hear you okay? We can't hear you. Thank Joyce. Thank you, Josh and Vicki and Joyce for picking up on that. My dog just did a mic check as well. For anyone who may just be on the phone and not seeing the chat box, Josh Gaither, who's the chair, is just switching computers, I think, to get his audio back. There we go.
Okay, is that better?
Yes, we can hear you perfectly. Thank you.
Great. Sorry about that. Wrong microphone selected. All right. Well, that procrastinated for the 2 minutes that I said we would procrastinate for, and nobody heard me. So I think we're good. Thank you guys for being here. We'll get things started. I understand there is something that needs to be read at the beginning. So whoever has to read, whatever it is, go for it.
Sure. Just a couple of notes and reminders. I hear an echo. Okay. So if you hover your mouse over the bottom part of your screen, the buttons appear for audio off or on, hang up / leave the meeting, and video on and off. Attendees are advised that this meeting is being recorded and will be posted on the ADHS website. So anything said verbally, viewed via webcam, and the chat box will become a part of the recording. Please make sure you're muting yourself when you're not speaking. I or Dr. Gaither will be displaying materials for the group, so there's no need to present your screen or share your screen. We'll monitor the chat box for questions. For everyone's benefit, please identify yourself before stating your remarks. And then if attending by phone only, you might need to press *6 to unmute yourself. And lastly, thank you for your participation and patience.
Oh, Josh,
sorry. Thank you, Julia. I hope the echo is not an issue on my end. Please let me know if you guys still hear an echo. I did not hear anything. Let's go ahead and dive in. Julia, did you want to drive? Do you want to review the draft minutes? I think actually this can be very quick. Participants, and the draft minutes is actually the document that we are going to go over. So we did briefly review some regulatory oversight, goals and objectives, and then we developed a draft document. So unless people have questions about the minutes, I don't think we need to approve them or anything. I think we can probably launch right into the purpose of the work group is the draft document that we have created. Any questions or comments about the minutes? All right, thank you, Julia. Let's switch documents then. So let me, if I can, I'd like to give the broad overview of the document, what we did last time, and then I'd like to dive into each of these segments for a more detailed review of each segment. So we really talked through this last time. It seemed that we wanted to address, common questions that arise from the field regarding blood use in the field and provide direction as to how next steps would be handled. So really what we did is we identified 4 or 5 major questions. The first being who can administer blood products. The second being which blood products can be administered. The third being which blood products should be given in the pre-hospital setting. And then the fourth, are there any guidelines for implementation of pre-hospital blood product programs? And I believe that was it. Oh, I'm sorry, one more. When should blood products be given? So I think the first thing I wanted to start out with for the group today was comments on this overall question. Are there things that is there some that we should eliminate from a broad question perspective? And feel free, I will also try to watch the chat, or for hands, you can do either of those options. If you're like me and sometimes click the wrong button, stick it in the chat too. Okay, we'll come back to this question again at the end. So keep in mind, if there are broad categories we are missing, please feel free to add those in. So let's focus on the first question, which is, who can administer blood products? And I'll read this statement just in case anyone's listening and can't see. In Arizona, the following healthcare professionals can administer blood products in a hospital setting. And we delineate two groups. The first when responding to 911 calls, and the second when performing an interfacility transport. When responding to a 911 call, physicians or nurse practitioners, registered nurses, and then it says blood products cannot be administered by paramedics, by a paramedic. There's probably a typo there, but comments or concerns about that first guidance? Okay. You're going to have to click your hand raise or talk fast because I'm going to keep going. So next group, when performing an interfacility transport, blood products can be administered again, physician, nurse practitioners. Blood products can be administered by nurses. Paramedics may monitor infusion of blood products after the sending facility has started the infusion of blood, if the medical director for the interfacility transport paramedic approves this skill. Any concern with the wording there? Okay. Hearing no comments or concerns, overall for this category of who can administer blood products, are there any red flags here? I will bring up one for discussion purposes. Physicians' assistants are not included in this list, mostly because I do not know the answer to that question, if they are allowed to give them on an interfacility transport. I left them off because I don't know.
That is a good question, Josh. I'm not sure. Josh, so I think when you're off mute, there's an echo.
Sorry about that.
That's okay. I think that fixed it. So I think the question about physician assistants is a good one. I'm not sure how many are working in the pre-hospital setting. They do have to work under a physician's license, but I'm wondering if that would fall under the way a lot of pre-hospital care where you're designating or delineating responsibilities. So that may be a potential where they would fall under whoever's providing their oversight or medical direction.
That's a good point. And I guess the question in my mind was, did we want to revise that line to be blood products can be administered by a licensed independent practitioner, which is somewhat, I don't know, my impression universally used to be MD, DO, PA, nurse practitioner. Really talking.
Well, Josh, this Garth came. I don't know if physician's assistants are truly independent practitioners if they are assisting a physician. I can buy the MD, DO, nurse practitioners as independent. I think just name a physician's assistant as able to administer blood products. Sorry for the echo.
No, it's my fault. There's something with my computer. Could I maybe ask, I don't know, maybe the Bureau staff would know who the appropriate, this seems to be something that we wouldn't want to speak to another regulatory in the DHS or within the Arizona government system. Obviously, I'm very comfortable on the physician part. I'm assuming the nurse practitioner's part. Is there any way that we can reach out to other groups within the Department of Health Services to find out if nurse practitioners and PAs would be allowed to do this?
So Josh, speaking to that, so ADHS does not regulate either of those groups. We had previously reached out to the nursing board regarding nursing scope of practice, and nurse practitioners do fall under their board. So I'm sure we could confirm with them. But my understanding is that nurse practitioners can operate independently. A physician assistant typically cannot operate independently. They fall under the medical board. So we can certainly have someone from our group reach out to the medical board and just confirm regarding that piece.
Okay. Thank you, Dr. Bradley. And then we'll leave it like this with a footnote to go back later. All right. Anything else before we move on? Okay. Let's then move to the next question. Which blood products can be administered? Here's the current statement. The Arizona Department of Health Services does not regulate the type of blood product that physicians, nurse practitioners, RNs, or advanced practice providers can administer. ADHS does regulate paramedic scope of practice and which medications paramedics can administer. Current DHS paramedic scope of practice allows for the administration of, quote, blood, unquote, during interfacility transports. Blood may be assumed to refer to both whole blood or any blood component, packed red blood cells, platelets, fresh frozen plasma, etc. Any comments or concerns with that kind of trying to explain the term blood?
I think that looks good, Josh.
Okay. Let's then go to the next question. Which blood products should be given in the pre-hospital setting? I think the kind of feeling from the group is that no current evidence-based guidelines exist to guide which blood products should be utilized in the pre-hospital setting. And we chose to list current options rather than clearly providing prioritized lists because one, we can't assume that everything's available or practical to be used. So what we listed, whole blood is an option. Advantages, contains all blood components and may be best suited for treatment of hemorrhagic shock. Disadvantages, limited availability and short shelf life. Packed red blood cells, advantages, commonly available with a longer shelf life. Disadvantages, single component therapy not well suited to the treatment, sorry, typo there, of patients who receive massive transfusions. So any concerns with those two before we scroll down to the next page? Okay, great. Continuing on, FFP and other forms of plasma. Advantages can be considered if more than 2 units of PRBCs are going to be administered if there is a known coagulopathy. I did not list this. I think we could come up with a list if you want. It's not a red blood cell. That's the disadvantage. I assume people know that, though. Any thought? Does anyone feel we need to add a disadvantage, or is that self-explanatory?
I mean, I think for those on this call, it is considered knowledge that this is not packed red blood cells, but for other people that may look at this, we may need to specify.
Okay. So Julia, are you going to make changes as we go along, or do you want me to?
Either works.
Okay, why don't you go ahead and type so everybody can see, and that way we don't have version control issues. So why don't we add one, disadvantages, colon, and I think my impression of what you said, Dr. Bradley, would be this product does not contain packed red blood cells and does not facilitate the transport of oxygen.
And does not, sorry.
Does not contain red blood cells and therefore, so the sentence would read, this product does not contain
red blood cells.
Red blood cells?
Yeah.
You can remove the pack.
Oh, gotcha.
And does not transport oxygen. Maybe we should include in there just a period. This product should not be used to treat hemorrhagic shock as a standalone transfusion option. Other comments from the group on the way that's phrased or written?
Oftentimes I'll hear it said, this is Paul Dabrowski. Oftentimes I'll hear it said that that it should not be used as a volume expander.
I like that. Great suggestion. Great. Any other comments on disadvantages of FFP? Okay. Moving on then, platelets and cryoprecipitate. Not recommended, a typo there for field use, unless part of an MTP program. I was hesitant when I drafted this to put in any advantage to this. I don't think many of us would use this as an isolated transfusion product for any patient, particularly without lab values. I see Paul nodding. Any other comments? Garth's agreeing. Okay. The last component we wanted to talk about briefly was RH factor typing. This may be confusing because it's obviously not a blood product. It's just a separate question. But let's run through it, and we may want to do this as a separate question. RH factor typing, best option, any blood product that has been matched to the patient's blood type. Second best option, O negative, female of childbearing age, O positive / negative in males. Alternatives, low titer O positive blood might be an alternative to O negative blood. At this time, limited evidence exists on the safety of low titer O positive blood in pre-hospital setting. Comments or suggestions on how we can improve the wording of this?
Josh, I think last time we alluded to the fact that the blood supplier or the blood vendor is going to dictate availability in certain parts of the state. American Red Cross has whole blood, I think, for O positive and O negative, but Vitalant, who provides blood in the Maricopa County and North, has limited supply of whole blood in the O negative. So we are using O positive whole blood. So I don't know if that's important to put in here, but just to make everybody aware that geographically, it's going to be dependent on vendor and what's available.
Thank you for that comment. It really does strike me, Vicki, that on that, this is really a separate question. So maybe we should phrase it as that. So Julia, why don't we do a bold header on top of this RH factor typing? And the bold header is, should pre-hospital transfusion programs consider RH factor typing in their, we can just limit it to that. Should pre-hospital transfusion programs consider RH factor typing? And then it probably needs some type of introductory sentence under that, which would be in non-bold text saying something like RH factor typing is important and should be considered in any pre-hospital transfusion program, period. The RH type of blood product administered should consider the following factors in addition to vendor specifications or something like that. We'll let you get that typed and then we'll all read it and make some suggestions.
I think I forgot the last word. I'm sorry. In addition to availability.
In addition to vendor specific requirements.
Requirements. Right.
Comments or suggestions on how we can improve that wording there?
Should we say instead of vendor specific requirements, maybe vendor specific availability?
Agree.
And I'm extremely impressed that Julia got to the end of that really long paragraph and only had one word she needed help with. When people are watching you type, I know I'm a mess. So.
Well done. Very good suggestion, Vicki. Thank you. Any other comments, suggestions? Let's then move on to the next question. Are there any guidelines for implementation of pre-hospital blood product programs? And the sentence here says Arizona DHS only regulates paramedic and EMT scope of practice. There are currently no Arizona DHS requirements or guidelines that EMS agencies must abide by when implementing a pre-hospital blood product program. However, any program that wishes to implement a pre-hospital blood product program should consider the following factors. I think my goal with this was to make it clear that there's no treatment guideline or anything that we can follow. However, there are certainly best practices. So one, pre-hospital blood product programs should avoid waste of blood products. And here's the suggested things. Agencies should ensure that blood products are stored at appropriate temperatures that meet all regulatory requirements. Agencies should ensure blood product temperatures are continuously monitored and aggressive quality improvement programs are implemented to ensure temperature spikes do not occur. Agencies should have a written plan to prevent waste and consider return, the typo there, of blood products to a hospital or blood bank prior to their expiration date where they are more likely to be used. Comments, thoughts on this first one?
My only question would be, do we maybe want to specify, when we say all regulatory requirements, do we want to be more specific, saying like all state and federal regulatory requirements, or do you think that that's explanatory?
I'll tell you why I picked this word. I didn't know which regulations apply. I didn't want to miss any. So I was purposely vague, but if anyone knows exactly which regulatory requirements fall on a blood product program,
How about just put meet all applicable regulatory requirements? And it's however it applies in whatever circumstance, then you've got it covered with the vaguity.
I like that.
This is Joyce. I have a question. Would would these pre-hospital blood product programs, would it be multiple programs in an agency, or is it singular, that they would have one program that covers the different blood products?
So I think almost universally, EMS agencies would have a single blood product program, and the medical director would have to identify which blood products were administered as part of that program. That would obviously be a decision that would have to be made in conjunction with the vendors of the blood products and those types of situations. That is a good question, Joyce. I don't know if we had made that clear in this document, that the development of a blood product program should be done in close collaboration with the medical director, the receiving trauma centers, those type of stakeholders. I'm going to take a note on that, Joyce, if that's okay, and let's come back to that at the end as something to address before we finish, if we haven't addressed it other places.
Yeah, because the question is, with the question in bold is singular. And so I when I was reading that, would an agency be confused that they have to have multiple blood product programs or just one? Thank you.
Okay, any other thoughts, comments? Okay. Number 2, pre-hospital blood products program should aim to optimize the benefits and minimize the risk of blood product administration. Sub-bullets, EMS agencies should implement clear guidelines/policies to ensure appropriate use of blood products. EMS guidelines/protocols regarding pre-hospital administration of blood should include criteria that prohibit the administration of blood products when the time to the closest trauma center is less than 20 minutes. This is a random number I picked. I think we need to discuss that. EMS guidelines/protocols regarding pre-hospital administration of blood should ensure that the administration of blood products does not increase on-scene time. And EMS agencies should have a strong quality improvement program that reviews every use of field blood products and provides performance improvement data to both EMS providers involved in the case and EMS system leaders. I think the overall goal of this, before we dive into the comments, was we know that prolonged field time in trauma patients is associated with mortality. I'll speak for Tucson Fire Department. The last thing I want for my Medic 16 crew is to wait on scene for 20 minutes for a truck to show up with blood when they could be driving the patient to the hospital. So that was the goal from my perspective when I put this together. But I think we can easily discuss some points here.
This is Paul Dabrowski. I'd like to suggest that in addition of the proper blood typing, or the kind of what we referenced above in the newly bolded section above about blood typing, since that is certainly a risk for patients, be carried down here. I don't know if you want to move that whole section down here, but I'm not necessarily recommending that. I'm just saying that if we're talking about risks, the typing risks probably ought to be mentioned in this paragraph.
Very good point. Thank you. I think referencing probably the section above may be the easiest. Julia, could we add in a bullet below the last one that says, I'm going to mess this up, so we're going to have to go back and re-catch it, that says essentially EMS guidelines/protocols should ensure appropriate blood products are administered, parentheses, including RH typing, for the appropriate patients. Does that capture what you're saying, Paul?
Yes. If anything, you could even move. You can even move that to the first indented. EMS agencies should implement clear guidelines, policies to ensure appropriate use of blood products. These guidelines, policies should ensure appropriate product administered, blah, 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 whatever. That would be, since that first indented talks about the guidelines and the policies.
Thank you. That's a great suggestion. So Julia, let's just, cut and paste that just simply behind the first bullet there. Perfect. Yep. Awesome. Okay. Sean says in the comments, should we consider a mechanism for reporting all pre-hospital blood products to AZDHS? Or should we look to include these fields in AZ peers or trauma registry fields? I'm going to punt. Someone from the DHS.
I am looking to see. I don't think we have anyone from our data side, but theoretically, any products administered, whether it be blood or medication, should be under the treatment section. So it should be something that we could query in AZ peers. Obviously, AZ peers is a voluntary registry. So there is no mandate currently in rule, although that may change, requiring agencies to report their EPers to the state. But I think we should have that information on there. I'll put that as a note to check and follow up with Ann Vosbrink, who oversees AZ peers.
Perfect. Thanks, Dr. Bradley. Any other comments on this segment here? Really aim to optimize the benefits and minimize the risk.
Josh, this Garth came in here. I'd like to have a kind of a triangular discussion with Dr. Dabrowski involved on the guidelines, protocols, prohibit the administration of blood products when time to the closest trauma center is less than 20 minutes. I just, I think we get into trouble with this depending on how we transport the blood products to the treating units and ourselves in the corner, because in the Phoenix area, this would preclude us from giving blood to those patients that really truly need it. And just thinking back on the San Antonio protocol, I don't have it in front of me right now, but there's an arm of that where you don't have to bolus with a liter of crystalloid first. I think you can leap directly to a blood product. So I think that there would be benefit for a person who really truly needs blood to be getting it en route, even if the trauma center is closer than 20 minutes. And that's just my thought. And I don't know what the right wording is, or I suppose there has to be some sort of statement just so that the giving of blood products is well conceived and well thought out, and it's just not willy-nilly. But I don't know what that statement should read.
Thank you, Garth.
This is Paul Dabrowski, and I would agree. I think I understand what Dr. Gaither was commenting on regarding, not wanting to wait at the scene for blood and things like that. And I completely agree. However, if the right time to give the blood is now, we don't want to wait 20 minutes to give it. So in general, I would say that perhaps the time to the closest trauma center, certainly could have a role there. But this one is a harder one to just define by minutes. There may be patients, if you have it there, to be given that of receiving blood, and certainly don't want to extend scene times for the arrival of blood if it's coming in other vehicles and things like that.
So I think there's another way to phrase this, but it's not going to make people happy. The other way to phrase this is to say blood should not be given in the field unless the responding paramedic has it. Right. And for Garth, you and I, that's impossible. I cannot give 25 medic trucks blood in my system. Not possible for anybody. But that I think is what both of you are getting at is, yes, I agree with you. If I am a doctor on a scene and I have blood and it's 5 minutes to the hospital, I'm going to start, but it assumes that I am on scene already. I think the goal of this is to not delay transfer to a trauma center. And I think we all realize that the worst thing you can possibly do for a sick trauma patient is sit and wait on scene.
I think the other issue is that of using blood products when absolutely necessary and sort of wasting blood products. So I think maybe the better way to phrase this would be if there would be a delay in scene time of greater than, I don't know, 5 minutes, something very short. I mean, I don't know how you justify prolonging a scene time of a sick trauma patient more than a minute or two. So I think if you phrase it that way, it's sort of the same thing, but in that you're defining it in terms of your scene time, not your response time to the hospital necessarily, because it's really what we're looking at. But
I could live with language, and I think Dr. Dabrowski was getting at this, that it should be stated that awaiting blood products or scene time should not be extended to await the arrival of blood products, period.
Right. Where the risk outweigh the benefits. Because I think if you start putting in actual time, then you box ourselves in place of clinical judgment. I think that's what I'm trying to say.
yeah, and I also don't know that there's clear benefit in the pre-hospital setting with short transport times.
Yeah.
Don't think there's enough evidence to support giving blood products to all trauma patients with a short scene time to the hospital.
But I think also what this gets back to is the point made earlier is we need a mechanism to track so we can almost review the cases and provide the feedback. So if we see that there are actual delays being in the setting, then we provide that feedback and course correct before things, outcomes are worse than initially thought they would be.
Vicki, if I could speak to that, I wish we had that ability in EPCR and run sheets, but we just don't get to that granular level of data, even with the best of documenters. I don't think we could piece out any accurate data on whether or not it truly delayed us leaving the scene. Yeah. So I wish we could, but I don't think we're there with the way we see pre-hospital documentation right now.
Sure, but I guess the question would be, is this an opportunity for a collaborative between our trauma centers and our pre-hospital staff? Because they're the ones that are on the receiving end, can give that real time. I don't know what it looks like, and maybe Dr. Dabrowski has some ideas, but I think that's the value. And if we're going to do something, we certainly need to be able to evaluate it and provide the feedback.
Thanks for those comments. If I can maybe redirect a little, just because we do have quite a long document to get through, can we close out some comments and revisions to this paragraph, and then we'll come back to the rest. So we already have in this document, EMS guidelines / protocols regarding pre-hospital administration of blood products should ensure the administration of blood does not increase on scene time. Kind of building on what Dr. Rice said, I agree with her. There isn't evidence that if I'll throw myself under the bus. It's 5 evidence that giving blood 5 minutes earlier is going to help. So I do think there should be some time in here. And I would argue pretty strongly, having spent a lot of time in the field and a lot of time reviewing cases, even if you say it doesn't prolong field time, it does. So, I mean, 10 minutes, 15 minutes, 20 minutes. I'm flexible in the number. I think we probably should include something in there, though.
I think it's a great idea to come back to it.
Okay, when are we going to come back to it?
I don't know. My vote is no more than 15 minutes. I mean, that would, I think, be the minimum to me in terms of where I feel like it would be prolonging the scene time greater than the benefit to get to the trauma center. Like, I think 20 minutes is a good number, but I think 15 would be sort of my minimum.
Other thoughts? I think when I look at this literature, the primary literature that has demonstrated good outcomes associated with field blood products has been almost exclusively in the military and air medical setting. And those transport times are in the 30 to 60 minute range. So very, very different populations, obviously. So I'm happy with 15 minutes. We can easily circle back around to it. If someone has a comment, you can type it in the comments.
If we have to have a number there, I'm okay with 15 minutes. Better than 20 minutes.
Agree.
Okay. We'll leave that for now. We can always circle back later, but at least we have something there. Sean, I'm purposefully, I'm sorry, ignoring your comment. I see it there. Should we look at a pilot project for real-time reporting and review? That's not within the scope of this group to address, so I apologize. We're really trying to address what is currently allowed under Arizona scope of practice. So thank you for the comment. I think we'll have to table that for another time. Point 3, pre-hospital blood product programs, sorry for the typo, should implement a comprehensive severe trauma care program along with their field blood product program. Some components of a comprehensive severe trauma care program should include advanced training in the management of patients with traumatic injury, implementation of guidelines/policies that include core trauma care procedures and medications to treat hemorrhagic shock, IV access, hemorrhage control following evidence-based guidelines for the control of hemorrhage, TXA, etc. I think I purposely added this in after our last discussion. My personal concern, and I'm 100% open to feedback, was that blood alone does not save somebody's life. Blood as part of a advanced, well-planned, with a good quality improvement program, trauma care program, saves lives. So I wanted to make that clear, but I'm happy to change this if this is unclear or you guys think it's redundant.
I think that's a nice add, Josh. I think it's important to recognize it's the entire body of care that it's provided in the pre-hospital setting that determines outcomes.
Okay, nods and thumbs up. We'll move on then. The last part, so I need to give a little background into this. At our last meeting, we had an extensive discussion about when should blood products be given. And I truly appreciate all of the input into that. Garth, thank you for forwarding the San Antonio guideline, the AIR methods folks. I talked with Dan David, their research medical director, about it. there's a lot of really strong opinions about blood product protocols. And then once I sat down to write all that down, I also realized that that's really not the goal of this committee. We were not really asked to do the job of PMD, the Policies, Medications, and Devices Committee. If we're going to develop a protocol, that needs to go through a different committee. So I kind of revisited this, and I'll read it to you and get some feedback with that background. Pre-hospital blood product programs are an area of rapidly evolving medical science. At this time, there are no widely published evidence-based guidelines or standards of care to guide when blood products should be administered. Should pre-hospital blood product programs become more widespread or evidence-based guidelines become available, protocols to guide pre-hospital administration of blood products would be developed by the Arizona DHS Protocols, Medications, and Devices Committee. So I am punting on this one back to another group, which I think would be better suited to do this.
I like it.
And Josh, if I might just make a suggestion. Sorry, there's an echo there. Just that we specify would be developed by ADHS Protocol Medications Devices Committee and forwarded to MDC for final approval, just to kind of cover the statutory process.
Thank you. Yes. Other comments, suggestions on this one?
Also, what would what would have to be taken up at PMD and later MDC is the change in the table for available agents to be used by paramedics in the 911 system to include blood products, but that, that's kind of a given in this case.
Yeah, I agree. And we did address that above, I think. So I'm happy to stick in a sentence here also to address that. I think that's a good point.
Up above at the beginning of the document, sorry to interrupt, it represents the practice as it currently is, and it might give the illusion that that's what we're settling for, but the whole point of this exercise is to determine whether paramedics can give blood and blood products in the 911 system. So yeah, I just don't want any confusion about that. That's the state of matters as they are. We're going to advise to PMD and later MDC a different state of affairs.
Thanks, Garth, for that comment. That also ties back into Joyce's comment earlier of, do we need kind of an introductory paragraph to explain the use of this document as an overall document? So let me get a feel for the group. Do you all think an introductory paragraph simply stating that these are recommendations for current use of blood products in the state of Arizona, and any program developed must be developed in close cooperation with the medical director and trauma system directors for your region? Something like that. Would that be helpful at the beginning? I see nods and thumbs up. Julia, could you scroll to the top and we'll put something down so we don't lose it? Yeah, just an introductory paragraph. Why don't we say something like, this document is intended to serve as a general reference for the pre-hospital use of blood products, period. This document serves to outline the current rules and regulations regarding blood product administration, period. Any blood any pre-hospital blood product program should be developed with input from multiple stakeholders, in parentheses, trauma centers, comma, EMS system leaders, comma, etc., and approved by the agency medical director. That's my off-the-cuff guess at this, so love feedback.
Good off-the-cuff effort there, sir.
Quit while you're ahead. That's what I say. All right. With that, I have nothing else to run through unless there are other overall comments, additions, subtractions to this.
So the timetable again, is this to be taken up at PMD in May?
No, I'll defer to Dr. Bradley on that one.
This is a work group from STAB, so this will go back to the STAB committee, and I think STAB is the next one in May.
Copy, thank you.
Good question. Let me then follow up with another question while we wait for any other questions or comments. Does the group feel like you are comfortable with this document where it currently sits, or do we need to have another committee subgroup meeting?
Josh, I think I'm gonna, if it's okay with Dr. Dabrowski, I'll talk with Dr. Dabrowski, and I'm still a little bit troubled by that one sentence, but I just don't know how to fix it on the fly, other than to maybe offer a suggestion down the road, maybe send it around by email to the rest of the group. But I don't think another meeting is necessary before STAB. But the commitment would be to come up with something that the whole committee is okay with before STAB.
And Garth, just because of open meeting laws, we cannot send something around by email, unfortunately, even though it's much more convenient. So we have to have that as part of the recorded meeting law.
You know, this is Paul Dabrowski, I'm gonna say that, you know, I would like to see something less black and white, like 15 minutes or 20 minutes or 10 minutes, or I don't know what that means really in regards to this document. Certainly, you know, how pre-hospital groups have dealt with other potentially life-saving interventions, intubations, and treatments for you know, for hemorrhage control and things like this. I would guess to think that there are not other documents that say do it if you can do it within you know, X time from the hospital or something like that. So I don't know if it should just be presented in a perhaps without the minutes, but in a little bit more vague way, acknowledging these other potentially life-saving interventions. I say that just for the record, so that way when we do start sending around emails, that'll be on there.
Yeah, I think what some of us are concerned about is it brings up something like targeted temperature management as an example, right? We adopted pre-hospital policies and procedures based on no pre-hospital data, and it takes time to go back once you've made a swing towards adopting a policy and then finding out in the pre-hospital setting that it actually causes harm when we do have the data. I think my concern personally is not being clear that there is not enough data here to make a strong suggestion towards blood products in the field. And that I wouldn't want a bunch of agencies adopting a practice that we later find out is, fraught with causing increased mortality because we prolong our scene times. That's my biggest concern with this. And I think without giving some sort of limitation or a suggestion of a limitation, that we run that risk. And I think that that's also something that's a significant concern.
So the next committee that's going to act on this is the STAB, correct? How about offering STAB a version A and a version B? I think that everybody's concerns are all wrapped up in the third bullet point under 2. And we can provide STAB with a version that includes the time limit, and we can give them a version B that does not have the time limit in, and let the trauma advisory board opine on this. The way that Paul, when we designed that pilot that we were thinking about offering up to the Bureau back before COVID hit, we were going to have all the battalion chiefs have blood, and we have more battalion chief vehicles than we have trauma centers. So I just think this limits that type of project to have a time limit, but that's just me. But how does everybody feel about that? Offer STAB 2 different versions of this, one with the statement, one without the statement?
One thing I just want to always preface, and it's something I think for me now being within the Bureau, it's been a good reminder, is that when we approve things at the statewide level, it affects the entire state of Arizona. And so not just systems that have highly engaged, highly involved medical directors, or just within the large metropolitan regions. And so we really need to just always keep that in the back of our minds whenever we do make recommendations or approve something that maybe is moving the needle a little forward with questionable evidence, just because we don't have necessarily everyone that's going to have an engaged medical director that's going to help guide those decisions. So I just put that caution, not voting one way or the other, but just recognizing that as we make recommendations, this would be for the entire state, not just for kind of the large metro regions with active engaged medical directors.
So I'm certainly looking for comments from other people on the call. I should have asked at the beginning. I am sorry, I didn't, Julia. There are 2 people who called in, so we can't see your names. Can you please identify yourself wherever it is that has a 1817 and a 928 phone number?
This is Ben Perry with Guardian Air in Flagstaff.
Jody Allen at Wickenburg Community Hospital.
Perfect. Thanks to both of you. Appreciate it. Any comments from either of you 2 or anyone else? We've heard 4. That's the minority.
Josh Noreen typed something in that I think I think I know the answer to this, but I think we better get this documented for the good of going forward. So will this be a TTTG or a guidance document? Well, I think what it will be is a change to the table for available agents for paramedics to administer, and then I don't know what it would be.
Let me clarify, Garth. So the point of this is to provide guidance to STAB on the current rules and regulations regarding blood product administration. Anything that has to do with TTGs or table, the drug table or anything else has to go through a different process that doesn't involve STAB. And I would echo Dr. Bradley's comment. My concern is STAB is not primarily a committee structure that involves medical directors. So I do have to think that we as medical directors have to really provide strong wording here to help out STAB, which is primarily a hospital-based committee. I don't have the membership of the committee in front of me. I don't know that there are many EMS medical directors on that committee.
So yes, just to summarize what Josh said, the goal of this work group was definitely not to go through the process of changing table 1, which is the pre-hospital drug table. I think the big question that had come up over the last year was questions regarding who could administer blood within Arizona, and there was a lot of confusion, even within the Bureau. And so we wanted to really delineate that there's many settings in the pre-hospital environment currently in Arizona where blood can and is being administered very well. So we wanted to delineate some of those pieces and make that abundantly clear. And then also look at, as these questions come out, what are some best practices and things for people to look at with that. So I think the goal for this work group is definitely not to address the drug tables, because that would go through a different process, which would be the PMD and MDC cycle. So there have just been a number of questions that came up at the trauma managers work group meeting. It came up at TEPI. And then also at STAB. And so we wanted to really bring kind of the subject matter experts from across the state, which is this group, together to really kind of come up with a nice summary document to present to STAB, which could then be disseminated most likely, I think, as a type of either just a reference or a guidance document.
This is Sean. And with that goal in mind, then I'm thinking perhaps we should strike bullet point number 2, as there is no evidence whatsoever on either end of the time frame with regard to pre-hospital administration. So if we're looking to just offer guidance about what people are capable of doing, what the regulations say they can and cannot do, and then what the best practices are, then we shouldn't include anything with reference to a time limitation.
Well, I think there is evidence for time limitations in terms of scene times in trauma. So I think that that's sort of what this is based in, is attempting to impart our opinion about, or not opinion, but the facts about prolonging scene time in trauma patients. So, I mean, I think that definitely is directly relevant in terms of if anyone is going to take up this subject in terms of moving forward from this STAB committee or any other committee, that has to be something that's considered. So maybe not specific with blood products, but there is definitely evidence about scene times in trauma.
But isn't that addressed in bullet point number 3?
So I'll offer my opinion, and I'm purposely trying to be quiet. I'm chairing the committee, but I'm also the medical director of a large fire department. I see routinely paramedics, and I have done this the same, so please don't get me wrong. I've been in the field enough to know I routinely prolong field time without realizing it. And unless you give people a solid reason, solid time, you lose track of this. I have personally spent, and I hate to admit this, 15 minutes on a scene trying to get an IV in. But I did it, and I felt horrible about it when I went back to review the case. But that's the type of blinders you put yourself on when you implement field blood product programs. You put yourself in the mindset of, I have to get the IV. This blood is going to save the patient's life. When in reality, I could have been at the hospital 10 minutes earlier had I forgotten that IV or tried to get it on the way to the hospital. So I personally, having been in there, done this, I personally feel we should be very strong on this language. And scene time and transport time to the hospital are two very different things.
This is Jody Allen from Wickenburg, and this is just my opinion. I feel like sometimes that when you put a specific number to it, it kind of locks individuals into situations by using, like you say, strong words of recommendation to not delay transport for a patient awaiting, blood. I think, using those strong words versus locking us down to certain minutes is a difference.
Thank you. Can I ask just for some clarification there? I'm not sure. There's a little bit of a bad connection. I'm not sure that I totally understood what you were saying. What was the suggestion?
My suggestion is not putting a specific number to specific minutes to being on scene, but like you mentioned, utilizing the strong recommendation wording that you do not delay transport of a patient awaiting blood. And then organizations evaluate their process and determine is there individuals that are delaying a transport based on waiting for blood, and have those conversations that we cannot be doing this. This is in the best interest of the patient to get them to the trauma facility, no matter, even though you're waiting for blood, but we need to get them to the trauma facility. But when you put a number, a minute to it, it kind of locks individuals in place when maybe a facility is carrying blood and can initiate that blood immediately. They could get that on board and going. And again, that's just my opinion.
Thank you. Other comments, suggestions?
So I think actually we just need to, I think there needs to be clarification, because I believe, if I am reading bullet point 2 first correctly, what we're stating here is that if the pre-hospital provider is less than 15 minutes away from a trauma center, then this committee would be recommending that they do not try to make sure that blood product gets administered. Just get the patient to the trauma center because they're within less than 15 minutes. Whereas bullet point 2 is saying those would be the patients that are greater than 15 minutes away from a trauma center. But at the same time, we're saying we acknowledge that you would maybe want to start blood products on those patients, but we don't want you to prolong your on-scene time. So we're actually saying two different things, if I'm reading this correctly.
Correct.
I think it's very important to have that delineation on those two and to include time. And the only reason why I say that is I'm sure all of us that, look at times in our trauma bays, if I didn't set times for my team in the trauma bay, just like Dr. Gaither said, they could spend an unknowing amount of time in the trauma bay trying to obtain something when they could have been moving forward to the next thing if they were focusing on their time frame. So I actually think that the time frame is a good decision.
So I think there's a huge variety of opinions here. So why don't we do this? Can we highlight this bullet in the document? And then in the highlight or comments, let's say for discussion at STAB. And we can discuss, and I'll bring that up with that group if that is appropriate, Dr. Bradley.
Yes, that definitely sounds reasonable. Oh, Josh, sorry if you could give me a second. I do think Kara's summary was really good, the way she described kind of what we're trying to delineate. And I think maybe that would help to explain that we're talking about kind of two different populations in a sense. And I agree, time frame wise, we've all been there, with intubating a patient, whatever the case may be, where you think so much shorter. And that's why our attendings in residency would stand over us with a timer and time us, right? Because we always thought it was a lot shorter period of time that it took us to get that procedure done. So I do think there's some benefit, but Kara, I don't know if you can maybe try rephrasing what you said, because I think you summarized it very nicely.
I'll try and type it out. Maybe it'll be better if I type it.
Thank you. Paul offered an alternative in the chat for those of you that can see it there. Paul's offered alternative was EMS guidelines. Protocols regarding pre-hospital administration of blood should discourage the use of administration of blood products when the trauma center is close by. And 15 minutes is close by. That's another way to phrase this. I think it's the same thing to me. I'm happy to cut and paste.
Yeah, I think I was trying to get away from the hard word prohibit to something else, and to offer a 15 minutes as a suggestion as opposed to a hard fast number. That was what I was trying to arrive at. So I'm sure it needs a little wordsmithing.
So I think this is probably one that we can take. The rest of this document, from my opinion, is very straightforward, very easy. It seems that we all agree on it. I'm putting words in your mouth. This seems to be the only issue that there's significant discussion about. So perhaps we take this document to STAB for discussion on this particular topic, and modify. That would be a fairly simple modification should STAB want to do that. Does that work for the Bureau staff?
Yes.
Okay, great. Thank you all. Other comments, suggestions?
Will we be expanding upon number 3 at all? I know that the EMS subcommittee for the Committee on Trauma, of which I'm a member, along with ASEP and some of the National Association of EMTs and Medical Directors, are currently working on a consensus document that actually will expand upon the items in number 3. Will that be left vague, or is there an opportunity to explore that a little bit more? What are your plans for that?
I honestly don't have any. I'm joking. I'm sorry. I think when I wrote this out, I was being vague on purpose. I did not want to include terms like PHTLS or other merit badges. I simply was looking to be, to frankly state that any blood product, if you don't do good basic trauma care, your blood product's useless. That was my goal, but I'm happy to rephrase or however you guys suggest it.
No, I think if we're going to venture out into the administration of blood, that it's always a good reminder that we need to do good hemorrhage control, whether that's direct pressure, whether it is hemostatic agents, whether that's tourniquets. We can't skip to the blood before we do some of the basics too, if that makes any sense.
Agree 100%. Thank you for that, Vicki.
Yeah, and I think that was kind of what was highlighted, but I think you're definitely expanded on that. And Josh's last paragraph that he added in is really emphasizing that this is just a component of pre-hospital care. Certainly, if you push blood in, but you're still bleeding, you're not doing any benefit for that patient.
Okay, thank you. Other questions, comments before we wrap up for today? Okay, thank you. I guess I will ask one more time. I am not inclined to have any other meetings. I think we're at a good point for this document to go to STAB. Unless someone speaks now, please forever hold your peace. And we will thank you all sincerely for your time and effort that it took to put together this document. I think this will help to answer a lot of questions.
Great work, Josh.
Thank you, everyone, for participation.
All right. Thanks, everybody. Have a good day.
Bye.
Thank you.